Thank you very much for joining everybody for today's session. This is the agenda. First, Dr. Amish Vora will give the conclusion from the board meeting that we had on 27th. And then we'll hand over to Dr. Raja for the discussion on COVID-19 vaccination for cancer patients and the consensus guidelines. And finally, I'll come back to share with you one slide on what is the agenda and the faculty for the next meeting, which is scheduled for 4th May. Next slide. So on behalf of the three of us coordinators, I hand over to Amish for the summary of the last meeting. Over to you, Amish.
Thank you, sir. So this is our second consensus slides. After every meeting, for the next meeting, we come out with consensus statements if we have reached consensus or we have not reached. So last time our topic was asymptomatic or mildly symptomatic COVID positive, of course, in cancer patients. Two cases were discussed. One was 34-year-old female, stage 3B SX Hodgkin's lymphoma with asymptomatic COVID infection. And the second was 61-year-old female, early breast cancer, post-operative on adjuvant chemo. Again, asymptomatic to mildly symptomatic COVID patient. Next slide, please. So the questions what we asked was as following. Should we be doing Rtpcr in all patients before starting them on chemotherapy each time? There was no consensus which was reached. Government hospitals, panelists said not to do, and private or corporate hospitals, they said to do, as even including the prevalence of COVID infections, what we are seeing. Next slide, please. What is the significance of cycle threshold value in Rtpcr report? The consensus was no clear data of its clinical significance. Follow government guidelines when in doubt. One question which was unanswered was, does CT value between 30 to 35 indicate mild non-infectious disease? That was something which we couldn't answer. Next slide, please. Should asymptomatic COVID positive cancer patients be admitted electively? Consensus was no. Uniform agreement amongst panelists was there, except when there is a very high risk of neutropenia or neutropenic sepsis in the following 7 to 10 days. Next slide, please. What investigation should we do for asymptomatic COVID patients with cancer? The consensus was it is okay to observe asymptomatic patients without any test. If there are mild symptoms, blood test on 4th or 5th day, which are pro-COVID inflammatory markers, which entire world is doing. CT scan thorax, no for asymptomatic patients. It is not required. Next slide, please. Would we treat asymptomatic COVID patients with antivirals? Unanimous decision was no. No favipiravir, no remdesivir. Next slide, please. If D-dimer is high, would we give elective anticoagulant to our cancer patients? Again, there was no consensus reached. All panelists but said, start anticoagulants at the slightest of doubt, that is in admitted patients, patients with comorbidities and aggressive malignancies. Next slide, please. Should we repeat Rtpcr in asymptomatic patients before restarting chemotherapy? Consensus was repeat every 14 days for patients on chemo till negativity is recorded. With this, I hand over the mic back to Dr. Parikh, sir. Thank you, sir.
Dr. Parikh? So you have to unmute your mic, sir.
Can you go to the previous slide, please? Yeah. So now we are into the meat of today's program, and that is the COVID vaccination for cancer patients. We have a very esteemed panelist and my dear friend, Dr. T. Raja, who is going to be moderating this. Dr. Raja has been, very, at the forefront to develop consensus guidelines as well. For his panel, we have Dr. Mukul Acharya, who is a clinician and now a microbiologist from UK. We have Dr. Ullas Batra, Senior Medical Oncologist from Delhi. Dr. Amit Agarwal, another Senior Medical Oncologist also from Delhi. Unfortunately, Dr. Hemant Malhotra cannot join because he has become COVID positive and is symptomatic. We have Dr. Chetan Damne from Tata Hospital, Mumbai, and Dr. Rajesh Jindal from Kolkata, who has converted his cancer hospital into a COVID vaccination center. So it'll be very nice what experience we have. So with this, I hand over to Dr. T. Raja to go ahead with the moderation of the session.
Thank you, sir. Thank you, Dr. Parikh, and thank you, Dr. Amish, and thank you, Dr. Sahoo, for putting us this series. And give me a minute, I'll be sharing the slides. So, good evening, everyone. And at this point, with really heavy heart, all of us, and I, on behalf of everyone, I too submit our prayer for the speedy recovery of our beloved friend, Dr. G.S. Bhattacharya, and also Dr. Hemant Malhotra. Just now I heard. And hope and pray they come back to us. They hope and pray with their full potential. Our heart goes to them. So today's topic is COVID-19 vaccination and cancer patients. So that's what we want to do. And all of you don't need, you are well aware, but allow me to just set the stage. And this is WHO Global Report, Epidemiological Update on COVID-19. And this was published, the latest was on 20th April 2021, and they have updated up till 18th April. And we see that uniformly across many countries and different continents, the second wave has truly hit. I mean, it's very clear, and each country is grappling with that in different measures, and the whole world knows that what India is going through. And this is also from the update that at present in India, the COVID cases per 100,000 population stands at somewhere between 200 to 300 population. This is as late as 20th April update. And so in this setting, particularly when we are dealing with cancer patients, and with regard to the question about COVID vaccine, there are still several questions and doubts in the minds of the patients, and actually in the minds of all us treating oncologists. So this panel discussion with our esteemed panelists will try to answer, if possible, some of these questions. And we earlier worked for a South Asian consensus, and I'll be presenting glimpses of that, some of the questions and answers and conclusions, so you can also comment and deliberate on that. So starting off with the panel discussion, this is the epidemiology update on the April 20, and this is where they have described the status in different countries on a very epidemiological term, and this is the new cases, so on and so forth, cumulative cases, and our transmission is classified as clusters of cases. Some other countries are put into community transmission, and we are called as clusters of cases. This is purely an epidemiological data set. So I will turn to our esteemed colleague from UK, Dr. Mukul. In your opinion, what do you perceive? This is the report, and you have, of course, learned through the various vernacular TVs and papers. What is your perception of what's going on in India, Dr. Mukul?
Oh yeah, this is very interesting. Well, I mean, first I would say it is an extremely sad state of affairs. The situation is quite grim, and obviously our heart reach out to everyone in India who's affected. This obviously the first thing, and it's very clear that this is a wave. It's more than a wave. You might call it a tsunami, which where you can see so many number of patients who are being tested positive practically every day, a lot of them requiring admissions. So essentially, the one or simple reason for this is obviously the variant, which has a very high transmissibility or a very high transmission rate, and hence it is affecting patients more rapidly, possibly even as rapid as the UK variant is what I can say. Two is, it means the guard was obviously down when it comes to social distancing, using mask, mixing. And definitely, because the guard was down, because there were no lockdown restrictions, they were quite relaxed for quite a few months actually, and that is the result. So when the guard is down and people are mixing, and then you get a new variant to which people have not been exposed before, the cases are going to go exponentially high, almost in geometric progression, and that probably is what is happening. Two, obviously, when you look at the distribution of this. There seems to be the cases being distributed in cities or metropolis cities which have got a high density of population. If you go towards the rural areas, probably the number of cases are less because the density is less. So the structure of India is such that most of the metropolis city have got the bulk of population. As you go towards the interior, the population is less. So high transmissibility and letting the guard down are probably two reasons. I'm sure there are other things to be considered, the number of admissions and the discharge, which we can, but I'm sure I'll let the other panelists answer that. I would be happy to fill the question after they have answered, but yes, because that is the other thing which I can give my thoughts later.
That is
Yeah.
Thank you, Dr. Mukul, for that.
Thank you.
And this is the vernacular, today's update on what's exactly happening in India in one of the one of the vernacular televisions. So I'm turning to my Indian colleague, Dr. Ullas. As you know, he sits in the real hot seat of the country, in Delhi, and he is also in a major center which takes quite a big brunt of these patients. So at the ground level, what is your perception, Dr. Ullas? Are you seeing that? What do you perceive about what we are going through? And you heard the comments from Dr. Mukul, and do you feel there is a glimmer of hope? Do you think this will fade away like all other countries, or do you think we are right in the middle of a deep sea?
I'll say everything. So I think lax public, no rules, mutant virus, overconfidence that we took the first wave very well was a recipe for disaster. And we are in the midst of the disaster. So all pandemics go on. In Hindi they say, bura hi sahi par ye waqt bhi nikal jayega. So this also will pass. We just have to hold on tight. We just have to take care. We just, as healthcare professionals and our families, have to make sure that our people, our near and dear one, and all our patients do not get engrossed into this wave right now. Because right now what we are facing is, and I can tell you my data, sir, we had 130 patients in COVID in last 10 months, out of which there were 12 mortalities in the last first wave. This 1 month, I have got 130 patients, 16 people have died. So the mortality rate is probably the same. But the problem here is that all of them have got compressed into one particular month. That is why the system has got overwhelmed, and that is why there is a panic. There is no oxygen, there is no beds. Mind you, mortality rate is slightly higher, again maybe because of the fact that we are not getting beds and stuff like that. It's not overwhelmingly high, but the point is the system has collapsed. That is the one which is issue over there. Now coming to Amish has asked me a question, how many of them were vaccinated? So Amish, from yesterday, this is the first panel in which I have read more than what I would read as a moderator. And we are also doing a survey. So we called up 50 people today, all people who came to my OPDs in the last 2 days. You know how many of them were vaccinated? Only 1/3. Why? हमने डॉक्टर से पूछा नहीं, हमने परमिशन नहीं ली, हमें लगा chemotherapy will get over first, so people are not getting vaccinated. I am going to come up and I'm going to take Dr. Parikh's help in some time when we publish our data, because 120 is a huge number which is coming up. I mean, we are going to come up with the data about how many people have taken vaccines, but I can tell you not more than 30-40% people have taken vaccine. But this will pass too.
Absolutely. So, you see that we have jumped from 4 weeks ago, like what you pointed out, this is an absolute overwhelming deluge. And yesterday was 360,000. And even though the vaccine efforts are happening, and you can see that India is the third largest inoculated so far, but considering our population, and we are still far away from where we should be. Totally, your points are taken. We'll moving on to Dr. Amit, Dr. Amit Agarwal. You think you just heard the scenario from Delhi, and you are also in Delhi, and I'm sure we hear and see what's happening in Delhi over the papers, and I have several of my friends there and desperately calling me to call someone in Delhi to get a bed and etc. So on and so forth. In all these things, we know that vaccine is important, but there are several questions regarding vaccine, just like what Rulas mentioned. So my first question to you is that do you think that cancer patients are more vulnerable to COVID-19 infection? And if infected with COVID-19, do cancer patients have higher chances of severe infection or death as compared to the general population? This was our survey question. I have displayed the responses from more than 100 oncologists. And what is your opinion on this aspect, Dr. Amit?
So I would assume that more vulnerable means they are more likely to catch COVID-19 infection. Is that what meant by the question?
That's the question. Cancer patients, are they more vulnerable, or are they more vulnerable to catch the infection? And if they catch the infection,
maybe because they come to the hospital and many other people are not coming to the hospital regularly. Otherwise, why would cancer patient make them more vulnerable? But I think for the second part, our own experience suggests that yes, they have a higher chance of protracted courses, severe infection and death. That I'm quite convinced about it. Are they more vulnerable? I'm not sure, but I think because they do have repeated hospital visits, that might make them more vulnerable, not just simply because they have cancer, but I think they're coming to the hospitals repeatedly.Maybe that is the reason. But I think second, I'm more convinced.
They have a disease which needs inevitable attention and can't postpone. Could be one explanation. We'll come to that. And the second part of the question is?
Second part, I agree that they seem to be having a worse course than somebody like an attendant of the patient or somebody else, as I see from the video.
Okay. I'm also going to take the help of, since Dr. Hemant is not there, I'm also requesting Dr. Amish and Dr. Sahoo to also pitch in. And so my question here goes to Dr. Amish.
May I say something?
Yes, sir.
Regarding the vulnerability and the increased, regarding the severity of infection and death, I believe in the first place, from what I know of and from what I have read, there are no studies or there is no hardcore statistics as to say that our patients are more prone to having COVID infections. And then there would be a lot of other things also happening to our patients. They may be elderly, they may have stage 4 disease, metastatic disease, their GC may be bad. So I think once we account for all these factors, only after that, I think we can say that our patients are more vulnerable towards COVID infection and the increased morbidity and the mortality with it.
Thank you, sir. I'm presenting a data set.
Dr. Raja, can I come in? Just 1 second.
I also want to comment after that.
Yeah, sure. Amish, please come in first. I will not get invited, no, Amish, again, no, to any other conference. So I have to respect you, first.
Okay, so I will, there was a data, Dr. Rajesh Jindal, when he said, ESMO 2020, the poster presentation is there from Germany, and there is one more poster from Italy, where they have looked at COVID positivity in cancer patients attending OPD, not those who are hospitalized. And they have found, as Dr. Amit rightly said, as good as any other non-cancer patients. In fact, they have done exactly the same. And right, Dr. Jindal sir, as you said, if you take the account of age and comorbidity, then the mortality is high, but it is not because of cancer.
Amish, I want to show this data. Just look at this. This is presented by multiple people across, and this was Cancer Discovery 2021 February. This shows this is kind of not exactly a meta-analysis, but it's kind of that there is a very classical, case fatality rate in patients with or without cancer. You look at this. All of these studies have clearly shown an increased case fatality with cancer and without cancer. This is across the board, different population, 800, 2000. This is a very, very compelling data set. And I also want to take you to the hazard ratios here. If you see, this increased case fatality is not only with the, in these public, you also notice that whatever be the number of patients that are seen, that means in a small center, big center, small country, big affected or less affected, the case fatality rate is on the right of the unity, significantly right of the unity. So there is now data that says that we are dealing with an increased possibility of mortality and morbidity in our patients. So your comment on that, on this data, and then Dr. Ullas wants to say something.
Sir, again, as I said, if you majority of these data would see first wave, which was there last year, and they have compiled the data and they have come out with that.
Yes, this is February 21.
Right. February they published, but at the same time, as I was saying that there was a huge 4-page review article on the data presented from Germany, that why are they different from all these meta-analysis or all these review articles. They have said majority of the case series which were published last year, they all were in hospitalized patients, and they found that patients with cancer who are admitted have higher fatality rate. But what we are saying is that OPD patients who are not admitted, and if you do Rtpcr on them, and if you do the outcome, probably this curve may merge, sir. That is what I'm trying to say.
Sure.
So, Amish,
Dr. Ullas, you have comment on this.
Dr. Parikh, please go on.
So, whether a patient is Rtpcr positive or not is immaterial. It is patients who get serious, who need admission, who need ventilation, and who die. That is the real important thing. And absolutely, there is no question, or there should be no question in anybody's mind that cancer patients are more vulnerable to serious infection and death because of COVID. Over to you, Ullas.
So, I am just quoting data. So, let's say general public mortality rate is 3 to 4% in the first wave. We had our mortality rate of 8 to 10% in our first wave. Hematology had a mortality rate of 20 to 22% in the first wave. So again, we were a part of TerraVolt study, which looked at only thoracic cancers. And there were 2 papers which were presented at ASCO 2020. One was by MSKCC and one was by TerraVolt. They reported 35% mortality with lung cancer patients and 25% mortality. Our mortality in the last 1 year has only been very close to some 8 to 9%. This wave is different. This wave has, taken away. Again, I said the system has collapsed, system has overwhelmed, and maybe something else has happened. Absolutely. I need more data. I will come up with more data, but this wave is slightly different. So, I mean, cancer patients are vulnerable more than the normal population, but definitely lesser than what the West experienced. That's my take on this.
Totally agreed, Dr. Ullas. We also have very similar experience like what you said. Last whole year until the second wave, we have treated more than 600 positive cancer patients, out of which I personally have treated 120 or 130 positive patients. But in the second wave, as you rightly said, in the last 1.5 months, I have already crossed another 100 patients, and our hospital has touched nearly 1,000 positive patients in cancer, and our mortality is taking it 6er. Now I am losing patients, a young patient today. I'm about to lose an 18-year-old girl, and who was absolutely fine, and some time ago, And I'm seeing very young patient, and wherever I test, it's earlier when I send from OPD, if I send 5 patients or 10 patients, I would get 1 or 2 positive. Now, if I send 5 patients, I would say 4 of them are becoming positive.
Do you know, sir, I am friends with a molecular pathologist. Last week, in Delhi, government reported a positivity of 30%. In our samples in Rtpcr and COVID gene experts that we do, out of 90, 67 were positive in the morning.
Exactly.
And in the evening, only 70 were negative.
Yeah.
So 70 were negative, yes. So, I mean, we had 60 to 70% positivity rate in RGCI.
Today, one day I have 4 patients and 2 of my doctors positive, 4 of my patients positive. So you can imagine, I mean, we are really, really, sinking feeling is there. Now, coming to the next part, I have to conduct the rest of the questions also. And even though sometimes, these are very, very controversial and very interesting. Dr. Sahoo, if you are there, if you can pitch in. And
yes, sir.
Yeah, should all cancer, the next 3 and 4 questions, should all cancer patients take the COVID-19 vaccine? 65% said yes. And if a patient has to receive a COVID-19 vaccine, which in the currently available in India is your preference, Covishield or Covaxin? Dr. Sahoo.
Okay. For all patients, cancer should take COVID-19 vaccine. For me, I think the broad answer will be yes, except for probably those who are just recovering from a stem cell transplant allogenic. That's where I'll put it. The rituximab data is dicey. But if you look at the ITSA and the ASCO consensus, they are also clear that they would recommend for this subset also vaccination, because they feel the benefit outweighs the toxicity or whatever, the lack of amount of response of immunity. That's what they mean. For the ASCO ITSA, when I went through, they are very clear for even transplants and even post-rituximab. They told we will recommend it because of the benefits, I think, is overwhelming more. Second point is for the Covaxin or Covishield, it will be a very clear answer for me. Whichever is available, please let us tell that we should be taking it for one specific reason, that at least the severity of disease and hospitalizations are lesser. So for that specific reason, I will tell whichever you get hand on, let it be a foreign vaccine, let it be Indian, just take it.
Okay. Now I'm coming to Dr. Chetan. Dr. Chetan is with us. He's special. He is a pediatric oncologist. We are going to come to some of the pediatric aspects also a little later. Dr. Chetan, if and when you counsel patients, we are going to talk about pediatrics later, but in general, this is among the available vaccines to your own friends and colleagues. Do you have a preference, perception among your colleagues, Dr. Chetan?
So again, I would just reiterate that whichever vaccine is available is the vaccine that you should take. But I think with the recent statement by Anthony Fauci saying that a killed vaccine would confer more immunity, and it makes immunological sense to take the Covaxin over Covishield. But again, the differences might be so minor that I would go with taking what is the vaccine that is available.
Fair enough. So now this is the next part of the question. What are the advantages and disadvantages of the available vaccine for COVID-19? And we are going to get into the nitty-gritties of vaccine in a minute. And I'm definitely going to get in Dr. Mukul here. This is really technical. Dr. Mukul, sir, your comments on these available vaccines across the globe and in India, of course, you are well aware that the Astrazeneca is available, and we also have the protein subunit vaccine, Novax. I'll present to you. So this is the advantages, disadvantages, and this is a pictorial representation of the same. And Dr. Mukul, your comment and your perception of vaccines available in your country and in India, can you tell us something more?
Good question. I mean, I think what we first need to understand is what we have here in the UK is essentially Pfizer-BioNTech, and in the Astrazeneca, which is Covishield, as you would call it in India. And I'm sure we probably would be getting Moderna as well. India has, I believe, 2 Covishield, which is AstraZeneca, and then India also has Covaxin. So when we look at Pfizer, Moderna, or AstraZeneca, so essentially these are mRNA, well, AstraZeneca and Moderna are mRNA vaccine, which means it is a genetic template which has been covered by a lipophilic molecule to prevent disintegration as soon as it goes into the cell or before entering the cell. And then once it enters the cell, obviously the lipophilic molecule is broken down, and then the genetic template is recognized by the cell, presented to the immune system, and so on and so forth. Same thing with AstraZeneca. It again uses a genetic piece of information specifically against the spike protein, but instead of, the vector is different. Instead of using a lipophilic molecule, it uses a modified, attenuated adenovirus, which is a chimpanzee adenovirus. So they have tweaked this particular information, the genetic information of spike protein, into the structure of the adenovirus, and they present that. And Covaxin, I believe, I've not really worked with Covaxin, but I know it is more of a killed vaccine, which is like the entire virus itself, which is being presented. So the nucleocapsid, the envelope protein, the spike protein, the RPDP, everything would be a component. So
I have also put in this cartoon, for totally ignorant people like us. Maybe you can use this also to comment on that.
yeah, sure. No. You're all very well read, and I'm quite impressed, with the knowledge and the information that you have. So that is commendable. And neither I'm a great expert. We are all learning, as we go, by as COVID-19 is presenting as facts. Right. So coming to the discussion now, logically, I believe someone said that when you use Covaxin or the entire virus, probably that is what Dr. Anthony Fauci said. It obviously will stimulate the immune system in such a way that the immune system would produce antibodies against every component of the virus. So that includes the nucleocapsid, the envelope, the RPDP, and the spike protein, and hence the antibody formation would be better. Is the general argument which is presented, as opposed to that when you use a mRNA vaccine like not AstraZeneca, like a Pfizer or a Moderna, or even the same thing with the adeno. We'll come to the AstraZeneca part later. They would only offer template for the spike protein, and the body would produce only specifically against the spike protein. So the argument is, here you have got the body producing antibodies only against one component, which is the spike protein, whereas there you've got the entire virus itself. So you've got a wide range of antibodies. But is that practical? So it doesn't happen. It unfortunately doesn't work that way. You see, when the body produces antibodies against all, it actually doesn't produce antibodies against all the components of the virus. The immune system selects the most immunogenic part of that virus and would produce antibodies, in a partisan way to that specific component than the rest. So the body would produce antibodies against the nucleocapsid or possibly the envelope, but they are not really immunogenic. The most immunogenic part is the S protein. Hence, the immune system actually would compete, the components would compete against each other as to which antibodies they should produce more. And finally, the most immunogenic part would win. Hence, I think producing, even if you give the entire epitope, it really doesn't work. A specific target like the spike protein, which is the most immunogenic part of the virus, when you use a mRNA-based vaccine, that probably would work more efficiently. Oh yes, the next question would be then, okay, what happens if the mutation, as we know, the virus has been mutating, the mutations have been happening in the spike protein generally, which obviously is the most important component for the virus, for it to enter the cell, to attach to the cells. So would there be an immune escape? The answer is yes, there is a possibility, though so far we've seen that the South African variant, the Brazilian variant, or even the Indian variant or the UK variant would still be covered by the mRNA, or that is the Pfizer and the Moderna vaccine, and as well as the AstraZeneca. So immune escape has not really happened. The efficacy would be slightly different between the three, but yes. And if we come to the next part, the fictitious case that, right, okay, now there is a mutation which really will escape all the three vaccines, what do you do? Fine, that should not be a problem, because the mRNA vaccines have been designed in such a way that they can go back to the lab, to the drawing board, tweak the vaccine. The genomic study is done very quickly. USA, UK, Europe, they can do it. Study the actual component, see where the mutation is, tweak the vaccine, and then start producing the next batch for the vaccine. So in my opinion, if I was given a choice and if I had the sort of access to various vaccines, I would possibly prefer a mRNA vaccine, the more targeted vaccine, as opposed to the general epitope of the vaccine. Now, where does this leave us with the Covishield AstraZeneca? So the AstraZeneca vaccine, no doubt, it obviously is a vaccine which still has exactly the same information incorporated, not in a lipophilic molecule, but just in the chimpanzee adenovirus, which has obviously been killed. There is an argument that what if people who've been exposed to this adenovirus have already got antibodies against the adenovirus? Would that nullify the AstraZeneca vaccine? The answer is no, because it's very unusual for all of us to have been exposed to the chimpanzee adenovirus, unless until someone's been working with chimpanzees their life or working in a zoo. That probably is a different thing. They have studied the sera of all these patients in the trial, and they have not really found antibodies against the chimpanzee adenovirus. So the AstraZeneca would also be good. So in my opinion, possibly Covishield would score a point against Covaxin, barring pending results of more trials.
Thank you, sir. That was really virological. It was really too much for us. But all I can add is that I have a different take on this. If I look at the inactivated vaccine, which is basically the Covaxin, at least successfully it has been already used in the polio, and the live attenuated vaccine has been successfully used in chickenpox, so on and so forth. And the non-replicating viral vector vaccine, which is the AstraZeneca Covishield, has been already successfully used in Ebola and various vaccines. The one question that I always had is the mRNA vaccine does not yet have until this particular COVID-19 vaccine came around, does not yet have a preceding successful large scale vaccine that has been proven, etc. But anyway, I'm not a virologist. I'm not even going to come anywhere near you. But I'm just trying to put this as a point. But I want to move on to a couple of other questions. With all these vaccines that we see, I want to ask Dr. Rajesh. But Rajesh Jindal, sir, if you think that, these vaccines are available, we are going to come a little later about your center experience also. But do you think this vaccine in general is less effective in cancer patients as compared to the general population, and therefore we need to look at them specially, differently? What do you think, sir, Dr. Rajesh?
About their effectivity in our patients, I really don't have an opinion. But from what I have read, it says that yes, because of the immune suppression in our patient, they don't mount a very good immune response against the antigens that we administer them, be it Covaxin or be it Covishield or Sputnik, which is expected later on. But do they need special monitoring after COVID-19 vaccine? Yes, I think they do, because I would think that two of my own patients, they landed with high fever. Although it was a week after vaccination, they were not neutropenic. Their white cell count was absolutely fine. And the fever also subsided after about, say, 3 or 4 days. So I really think that they should be observed more. It may not be because of the vaccine, but still I think observation would help in those patients also.
Yeah, right, sir. I think this is exactly the reason. If you look at all the questions, I have a few more questions.
Dr. Raja, can I come in for a minute? Just a short answer.
Sahoo, yes,
Dr. Sahoo, yeah. There is we don't have level 1 evidence for the cancer patients COVID vaccine, but there is a data which has come from a group analysis, and they have found a very interesting, which there's a publication to that in cancer patient compared to the general population, they found that post 1 dose of vaccination, the amount of immunity, the amount of antibodies found was lesser post first dose. But second dose, they found that it was matching the control of the normal population. Although with all the caveats that it is not a randomized study. So the take-home message should be that if a patient of cancer gets vaccinated, he should get it probably the second dose as quickly as possible, maybe the 4th week as recommended, not delayed. But post second dose, the mounting of immunity amount of antibodies is equal to the normal population. That's a small addition.
Okay, thank you for your input.
Dr. Raja, can I come in?
Yes, Dr. Ullas. Before that, if you notice this question, what happened is among all the respondents, this is one question, but in which a majority of them ticked not sure. That was, you can, this question
I was coming to.
Based on factual data, they were trying to answer hopefully, and then that is why they all said that they are not very sure. That's a very candid and honest reply from our oncologist. Dr. Ullas, your take on this?
So I am just going to, so I mean, I told initially, this is one panel in which I read more than which I was moderating. So on April 27th, that is, I think, day before yesterday, in Lancet Oncology, I think the data that Sahoo was speaking about has been published, which basically says safety and immunogenicity of 1 versus 2 doses of COVID-19 BNT, that is a Pfizer vaccine. And what Dr. Sahoo said was absolutely spot on. After 1 dose, the efficacy was only 42%, but after second dose, after 21 days, the efficacy was around to the tune of the similar as what we see in the general population. So
Exactly.
cancer patient. So this is the published data right now, sir.
Yes. See, the publications are about to come. I mean, are just coming in. This is, as you both said, this is again the Lancet Hematology, 20 April 21. First dose of COVID vaccine can trigger immune response in myeloma patients 70%. So the data is emerging. So we'll, I mean, like probably what you both said, probably will correlate with the forthcoming data. We look forward to that. So there is publications emerging. So we'll look at that. And so therefore, Dr. Amit, to you, we are now getting into some of the nitty-gritties of what we have to advise to our patients. What would you prefer vaccine advice for a cancer patient if you are going to initiate a treatment of a patient, and then, or if the patient is going through the cycle, probably is about to complete, and these kind of patient set, how are you advising your patient, Dr. Amit?
So my basic focus is to get vaccine as fast as possible. I try to keep a gap between the chemotherapy and vaccine of about a day or two. Try not to mix up the toxicities of both together. And it doesn't matter to me whether the treatment is nearing completion or not, but I try to convince them that it should be incorporated sooner the better. Maybe not on the date of the chemotherapy.
So that is your take, and sooner the better. And we are going to come into a little bit of nitty-gritty of this. And so I'm going to ask, Doctor, again, I'm going to take Dr. Mukul's help here. In your opinion, Dr. Mukul, what do you think? These are the questions that we asked our, all our oncologists across. We used a Delphi system, actually, Delphi, in which what we did is we conducted the survey on 3 different time intervals over a period of 60 days, so that sometimes the emerging data can kind of consolidate your thought process. So that is how we elicited the responses of more than 100 oncologists, and then a large panel of 35 oncologists and hematologists all fit together, and we have come out with consensus. I'm going to also touch upon that. But this is what we try to do. And these are the questions that I have. What is the best time to get COVID-19 vaccine? And in which 41% said that immediately. Whereas, there were some answers, 22% said after 1 month, and 13% said after 3 months. And then, if a patient has recovered from COVID-19, would you give it? So 84% said immediately. And if a patient has recovered from COVID-19, cancer patient, and needs to be vaccinated, should the decision be taken as for a normal person without comorbidities? The answer was again a majority, 73. So these are our responses, and your expert comment on this aspect.
Thank you, Dr. Raja. Yeah, I mean, this is an interesting. So the first question is, when should patient receive the vaccine, especially patient who are cancer patient and who are probably going to receive SACT, systemic anti-cancer therapy? The ideal thing, if you have the time, meaning if the patient is being seen in the pre-cancer therapy session where the patient is going to be counseled about receiving or starting cancer therapy, and if you can afford to wait for the chemotherapy to start, I would probably wait as per the UK chemotherapy guidelines, Board of Chemotherapy, 2 weeks. So I would leave a gap of 2 weeks where I would sort of give the, administer the COVID-19 vaccine, wait for 2 weeks, and then start the chemotherapy. That is in an ideal world, if it is possible. So when the first time you see the patient, you need to counsel the patient and give the vaccine. But that usually doesn't happen, because sometimes you see the patient in the 4-week rule and you need to start the chemotherapy, yesterday. Well, so obviously you missed the boat. So the COVID-19 vaccine can be given even a day before starting the chemotherapy. So if the patient is going to be on cytotoxic chemotherapy, then COVID-19 vaccine can be given day before. If the patient is going to be on monoclonal antibodies without cytotoxic drugs, or if the patient is going to be on immunotherapy, or if the patient is going to be on small molecule protein kinase, you can give the cancer therapy the COVID-19 vaccine anytime. Time is factor is not a problem. So except for cytotoxic drug, which obviously you cannot give it on the same day, but you can give it a day prior to starting the chemotherapy. But yes, the COVID-19 vaccine should be given. Obviously, we can go into more details of that, as to what other drugs and specific timing.
We are coming.
We can come to that later. So that's one. The other thing is, do you want me to answer the second question? Should cancer patients who have recovered from COVID-19 get vaccination? Oh yes, certainly. So cancer patients who have recovered from COVID-19 should get vaccination, yes, at the first available opportunity. Because even though they have recovered, so when can they get the vaccine is the question. So the point is, as long as they are not acutely neutropenic, which means the neutrophil count is more than 1, it has gone up to more than 1 without GCSF.
Okay.
You see, because when you give GCSF and you look at the count can be 1, 2, 3, 4, 5, but those neutrophils are not functional neutrophils, as you would agree. You see, they are just a response, a knee-jerk response by the body to produce neutrophils to the GCSF. So when the neutrophil count goes to beyond 1 without GCSF, that is the time when you would give. The other thing to look at is sometimes you may have to look at the platelet as well. So as long as the platelets are more than 20 into 10⁹ per liter, that is what we look at. As long as the platelets are more than 20, you can give. You just need to counsel the patient. The chances of bleeding are slightly more. It is only a small dose, 0.5 ml intramuscular injection. Give the vaccine and give sort of pressure for at least 5 minutes, and that's all you really need to do. So neutrophil count and platelet count are extremely important. For cytotoxic therapy, 1 day before. For any other therapy, can be given anytime in between.
Absolutely, thank you. This is exactly our consensus also from our entire South Asian declaration.
Yeah.
It's like give COVID vaccine now. I mean, in almost all our patients, we are giving it today. That's what we do.
Absolutely.
Tomorrow chemo, today we give, and in fact, I don't think there is anything contraindication to give it on the same day also.
True.
And if there is a myelosuppression, yes, all of us, as you rightly said. And this is the answers from, on a cartoon that we have displayed a survey from our oncologists.
Oh yeah.
Most of them would want to do it immediately. There are some doubts. Probably they base their doubts on neutrophils and platelets, so on and so forth. Then we are going to also try answer these questions based on immunosuppressions. Dr. Amish, would you take this question for us that can you classify your patients under the degree of immunosuppressions, and based on the therapies that they are going to receive, would you make your decisions based on that, Dr. Amish?
Amish just got an emergency, so he's here.
Yeah, sir, can I be excused because I'm just working on one similar 18-year-old boy trying to.
Oh, please carry on, Dr. Amish. Dr. Sahoo?
Yes, sir, please. Any potential challenge of forcing generating adequate? Okay. I don't feel in solid tumors this could be a big issue. The only concern would be with someone who's taking rituximab probably, or probably someone with a very myelosuppressive or a post-stem cell transplant immediate. So that is the only two subset of patients which I feel we could wait for around 3 months post and then vaccinate them. So that is my take on the first
Do
question.
you have a take on, you divide your patients into severe immunosuppression, moderate immunosuppression based? I've just given some examples, and this is based from, publications in immunopharmacology, that you divide them into some moderate, severe, and then base your decisions. Your comment on approaching this way, Dr. Ullas?
So, if you had asked me 45 days earlier, my answer would have been different.
Okay.
At that time, we were not in the midst of the wave. The COVID was just 200 cases per day in Delhi. And I honestly have told my patients, maybe cancer patients won't mount an improvise during weekly paclitaxel. So maybe we can give it at the end of the treatment.
Okay.
Today, I say, please don't. You can stop the damn chemotherapy, but please don't stop your vaccine. That's my point nowadays. So nothing, after having seen the way COVID is affecting cancer patients, one thing that they need is vaccine as early as possible yesterday.
As early as possible yesterday. Your point is well taken. So then why there is so much reasons for hesitancy until yesterday, see in India, what happens is, and the vaccine is available and you see the centers morning till night. I have walked into my center, trickle of patients. The moment we say that last week we ran out of vaccines in our hospital, then I get every patient on my doorstep, doctor, can you please put in a word? So in India, there is always a rule. If we don't get something, then it is more important. Then we have to rush and get it. That's our attitude. But I will turn to Dr. Purvish. What do you think are the possible reasons for hesitancy? Is it because of perception among the patients or the family and the doctors also, many of the doctors, about COVID vaccine? Dr. Purvish, can you address this question?
Yeah, so I think that is a very important question, and that is one of the main reasons why India is having this problem. Among our healthcare colleagues also, the number of people who have refused vaccination are very significant. And if we are not convinced ourselves, how can we convince somebody else? That is a major problem. The second problem is the university of WhatsApp. There are so many fake messages and fearful, ramifications that this will happen and that will happen, that patients are confused and then they don't know what to do. And as an inaction, they will postpone the decision, and that is why this is a problem. But I think if we can do everything in our power to overcome this vaccine hesitancy, we can do a big service against the COVID pandemic. Back to you.
Yeah.
Sorry, can I just come in for a minute, Dr. Raja?
Yes.
If you don't mind, I'm sorry.
Please.
We were discussing chemotherapy, and then someone mentioned rituximab. I would like to make one point. See, rituximab, as compared to all other biologics, is a slightly different drug because it is one medication which causes B cell depletion. Now you have to be very careful about the timing of COVID-19 vaccine.
We are going to talk about rituximab.
Oh, right. Okay, fine.
We'll definitely take you. See, this is a survey that is conducted on 5,000 plus patients who have received COVID vaccine in India, and this was published, India Med Review in Jan 21. This is symptoms post vaccinations. 5,000 is a robust number, and these are the post vaccination symptoms. And thought is that whether this would be one of the cause for our vaccine hesitancy, and apart from our mindset, apart from that aspect what I mentioned. And so therefore I am turning to Dr. Jindal. Dr. Jindal, you are not only, you have now converted your cancer center into a big vaccination center, and you are kind enough to share these slides with me. And you have started vaccinating actively from March 21, and you have now already touched upon 500 patients, and these are the side effects profiles that you have documented. Sir, can you comment on the side effects, vaccine hesitancy, and your experience in your center, Dr. Jindal?
Sir, it was around the first week of May that my district authorities asked me to step in and help them, which we readily agreed to. We have vaccinated about 500 people, although we would have loved to do higher numbers, but the supply of the vaccine was a major issue. Regarding the hesitancy in our patients, I would disagree with Ullas that patients don't want to get vaccinated. In my center, it was the other way around. Right from day one, I had lots and lots of people waiting for vaccination, asking for vaccination, including cancer patients. I mean, the rush was so heavy that I had to create separate sessions for my patients. I could not have accommodated in the regular patients. As regards the side effects, I mean, we made it a point to ring up these patients after 3 days. All the patients, we rang them after 3 days just to ask if there was something wrong with them. Just about 10 patients in all, and a large number of them, I would think about 9 out of these 10 reported this pain at the site of injection after the first dose, not after the second dose. After the second dose, it was just one lady who commented that she still has a pain in the left upper arm. As regards body ache and fever, it was just reported in one patient, and she was my own radiation oncologist, that she received the vaccine, and then the next day she got high fever and body ache, and she stayed at home that day. But besides these, not much else, and not any more side effects. But then, yeah, I think that is all that I have to say.
Just allow me to have one comment, and just to lighten the mood in our hospital. I saw that most of our senior consultants, they would take the vaccine and then come to the OPD to start working. And most of my young registrars, after the vaccine, they wanted half a day leave and they went home because they presumed. So it was fun, just to stay like that. But they are entitled to leave, so I can't do anything about it. So that's about it. And now coming into some of our the issues that we wanted to go on, what factors could be important for COVID as far as hematological malignancies are concerned? So I'm going to ask this question to Dr. Amit and to Dr. Chetan. Dr. Amit.
I think I would have to pass that question because I hardly deal with hematological malignancies.
No problem. We'll come to that. Dr. Chetan, can you take that particular question, hematological malignancies? Dr. Chetan, sorry, are you there?
Maybe we should go ahead. I don't think.
Yeah, I've just come. Sorry, I missed the question.
Sorry. I was just talking about hematological malignancies, and we are going to come to some of the aspects like rituximab and transplants in a minute. But in general, a comment is about hematological malignancies and the vaccines. What is your comment on that, Dr. Chetan?
So I think the patients with hematological malignancies receive a lot of myelosuppressive agents, a lot of agents that are lymphocytotoxic, and there are the chemotherapy is dense, as well as you receive a lot of steroids. So definitely, I would say that these patients should get vaccinated, but they should be monitored. We are not sure whether they will develop immunity. So I would wait, especially if they are on active chemotherapy, I would wait for a period of time, at least 2 weeks before I give the vaccine. And again, if I can interrupt therapy, that would be something that I would like to do, but I might not have the luxury to do that. So between cycles, I would give the vaccine for these patients.
We asked some specific questions to our consensus, across. Can patients receiving rituximab be given COVID-19 vaccine? In which, surprisingly, majority, 42% said they are not sure. And again, 55% of them said that they are not sure whether the COVID-19 vaccine is safe in stem cell transplant. And active malignancies, that was probably a little trick question. Most of the time we deal with active malignancies. Can other vaccines can be given along with COVID-19 vaccine? This you might see in a post-transplant recovery setting. We often talk about multiple vaccines. Again, 44% of them said they are not sure. So this is what we consensed that.
Dr. Raja, can I come in for a minute for rituximab?
Yeah.
I think the point is what the previous Dr. Chetan told is the lymphocyte count.
Yeah.
you should have a lymphocyte recovery of at least 1,000.
Okay.
If you don't have it, that will be a problem because they would not be able to mount the humoral response. Or they have told of a B cell of 50, which I don't think anyone of us measure the B cell exactly as it is. And if you have to give it prior, if it can be given, they want at least a 2 weeks gap from a COVID vaccine to the initiation of the rituximab or something of that lymphodepleting therapy. So that is one point, that if you start it, that should be a gap of 2 weeks. But if you want to give it after, the recovery of lymphocytes should be beyond 1,000. For rituximab, it is preferable beyond at around 6 months after the completion. That's what it is, because they would not be able to mount the amount of humoral.
Agreed. Dr. Mukul, therefore, now your comment on these two questions, rituximab and stem cell transplant.
Okay, so as far as rituximab infusion is concerned, as Dr. Sahoo has already said, yes, it is something which depletes the B cell. So if you have a patient who obviously needs, he is on, or he is going to be commenced or has been commenced on rituximab infusion, and he is going to need the COVID-19 vaccine, how would you go about? So ideally wait for 4 weeks before the next dose, is to be given. So you have to give the COVID-19 vaccine. There has to be a gap of 4 weeks, 3 to 4 weeks later, which means if someone has received rituximab infusion, then wait for 4 weeks for the recovery, give the COVID-19 vaccine. Then I think the next dose is usually 5 or 6 months later is what you would be giving the infusion, 5 or 6 months. So the essential thing is you don't have to wait for a long time. 4 weeks is what has been recommended by the UK Chemotherapy Board, as well as by the Joint Committee of Vaccination and Immunization. So 4 weeks time is the key rule, the thumb rule to wait. Then sort of start the next rituximab infusion. Again, how much should be the duration between the 2 doses of vaccine? So in UK for AstraZeneca, we've been using like 12-week duration, because just to try and give the first dose to as many people as possible. But I think as far as these patients are concerned who are on biologics or rituximab or chemotherapy, I would actually reduce the interval between the 2 doses of vaccine, and I probably would give them at say 6 or 8 weeks time. But before the next infusion, 4 weeks should be the minimum.
One of our colleagues today is asking, do you have experience on daratumumab? And
well, I must confess,
myeloma, it's a anti-myeloma drug, and so therefore they want to know, that's a monoclonal antibody.
Yeah. Okay, fine. I mean, to be honest, as far as monoclonal antibody is concerned, as long as it's not a B cell acting antibody, there should be no problem. Yeah, you can give 1 day before. You can even give during, in between the infusions. That's not a problem. These 4 weeks duration is specifically for rituximab.
My specific question, sir, was because of the daratumumab acting on the plasma cell, the CD38 blockade.
Okay.
So for multiple myeloma.
Yeah, that's absolutely fine. I still would not hesitate to give COVID-19 vaccine, because when we've already seen plasma cell it's fine. It will not actually interfere with the immune response, which is classically B cell and T cell, CD4, CD8 cells. So I would not be worried. I would use it.
You are out, Dr. Raja.
Yes.
I mean, in the setting of lymphomas, leukemias, myelomas, hematological malignancies, lymphocyte depleting therapies, wouldn't the recommendation of vaccine also be dependent upon the transmission rates? Because if the transmission rates are high, then I might as well vaccinate them now.
Actually, you are right, sir. That is what our consensus tried to capture. And yes, we have already shown that not only that we take these into consideration, I'm just trying to, we say that in a low spread area, high spread area, as Dr. Ullas, I think, mentioned that in another context, that when you are right in the middle of such an overwhelming, stop everything, don't worry about anything else, just go ahead and vaccinate. That could be. So your point is well taken. And now coming to another question, just to cover all angles, post-vaccinated patients, should be, what about their travel restrictions, and whether they can move around freely? And this question I want to pose to Dr. Purvish, particularly look at the CDC recommendations that came about a week ago that created a lot of controversies. American CDC has now said that all fully vaccinated people can do whatever they like in the outdoor. And will that be? I mean, of course, in our country, this will be a disastrous advice, but eventually, at some time, what is your comment on this CDC guideline, Dr. Purvish?
So I would agree with you that we should not follow the CDC guidelines. Point number one is that the vaccination might protect the individual, but it does not prevent that individual from carrying the virus and transmitting to others. So if everybody in the room is vaccinated, that's a different story. But we are not sure what is happening elsewhere. So I would not do that. And in fact, your colleague, Dr. Ghafoor, has sent a letter to the Prime Minister saying that, because of this situation, the vaccinated people, whether they are with cancer or without cancer, should have the same restrictions for travel, but everybody should continue to wear masks and maintain physical distance. Back to you.
Yeah, your point is taken, Dr. Ullas. So amidst this overwhelming second wave, what will be our new considerations? Should we say that mask at home, mask at all places, vaccinate everybody in the household, everybody in the universal vaccine? So what do you think about these kind of thoughts, Dr. Ullas?
So definitely mask at all the places. I have not taken my mask. If you can see my nose, there is a big scar on my nose because of last 1 year. I have not taken my N95 out. Mask at home, I think slightly, slightly impractical probably. There are people who have been doing it, especially if majority of people are not infected, they have been doing. I'm not so sure about the practicality of that. But the moment I step out of my house, I would definitely, mask myself. I'll mask my children. Everybody in community, yes, vaccination is the only way by which we can make COVID a normal viral influenza-like disease and not get scared of. Because if we don't die, if we don't have severe infections, it will be okay. Third is, what about children with malignancies? Why children with malignancies? My wife is a pediatrician. First wave, she hardly saw any pediatric people with COVID. This time the youngers are getting infected. She just lost a newborn 3 days back with COVID. Wow. So it is affecting newborns also, children also.
Yeah, that was my question, and I'm turning to Dr.
Sorry, Doctor, I just need to add quickly about infection prevention control.
Yes.
So I think one important point which we need to make is when you have a patient with cancer who's going to be starting chemotherapy, you not only offer vaccination to that patient, but also to the entire household. See, because there would be young patients, there would be children who would be carriers of COVID-19, who would give it to the cancer patient. So not only the patient who is being scheduled for chemotherapy, but the entire household. That's one. Two is wearing masks at home. It is impractical, but I can do something from my experience. See, I obviously, when I do my duties, I do rounds, I do IC rounds. We as microbiologists, virologists here we almost are like infectious disease physicians. So we proactively go to wards, we do stewardship, we see patients. We sometimes have to go inside the ICU to the COVID area. So when I used to come back, till last time there was no vaccine. Obviously, me and my wife were isolated, but we were in a bubble, obviously, because I was staying with my wife. My son was staying somewhere else. I used to sort of, make sure that I used to wear a mask even at home because my wife was not protected. You see, even though my wife was not going out, I was obviously the one who used to come back and bring everything I can. So honestly, I was scared and I didn't want to give it to my wife. And I wore a mask, and we used to sort of, maintain social distancing. Till last this time, both me and my wife received both the doses of our vaccine, then the mask is down. People might find it a bit funny and hilarious, but no chances to be taken, honestly.
Right advice.
I would just like to come in here if I can.
Yeah, please. Yeah.
Yeah. So there was one question previously that was unanswered, is about, can COVID vaccine be given with other vaccines? Yes. And I would say that yes, especially for pediatrics, if you are giving your routine vaccines, you can combine the COVID vaccine with it. So that should not be a problem, because we always give a cocktail of vaccines, but it should be taken on the same day. The other thing is, as Dr. Mukulacharya mentioned, we are focusing only on our patient, but I think it is very important to focus on everybody around. So if you create a herd immunity around the patient, that would be very useful for our cancer patients. So that is one point I would like to stress on. The other thing I would say is that for children, we should, as soon as there is safety data of the vaccine in children, we should go ahead and give all the children vaccine, because once we start schools in India, it is going to be a disaster again, and that is where I expect the next wave to come
So,
in.
Dr. Chetan, I'm coming to you on these questions. Same.
Yeah.
Why one of our colleagues in our today's attendees have asked, why is it that the second wave is picking more younger patients? Children are affected, and all of us just now mentioned. And I've just put in the management of child with COVID-19 here, and this is the Moderna has started trial on COVID-19 in under 18 and under 12. So the point is, why children are now becoming more vulnerable, and you already partly answered the question, but touch upon children and COVID vaccine in children.
Yeah, so as you just said that previously all the schools were off, people were doing online schooling, so probably they were indoors and they were protected, but they are not immune to the virus. They will get the virus, but they will not have severe disease. So that is something that we have seen in the previous wave. This wave we are seeing more children affected, but again the mortality is definitely lower than what we have seen among adults and people with comorbidities. So I think children, we don't need to worry about so much about them getting serious infections, except for the neonates and infants. But I think seriously that before school starts, all the kids should be vaccinated, so that we can prevent the spread of the disease. And in India, 30% of the population is below 18 years of age, or maybe 12 years of age. So that exact number we need to figure out. But that's a major chunk of population that is going to be transmitting the disease to the households. So that I think should be one of the primary aims that we should have.
Thank you, sir. And this is the ESMO roundtable that happened a couple of months ago, and they named it as the known, unknown, and unknowable of cancer 19 vaccine. And they came out with a consensus first published in December 2020, and it was updated in 27th April 21, just about 2 days back. I'm very proud to say that I went through the entire consensus, and our consensus, what we have now sent for publication, the South Asian, I urge you all to look at it, is more exhaustive than the ESMO consensus roundtable that was updated in 27th April 2021. But we will come to our expert, Dr. Mukul. Sir, can you tell us anything important in the ESMO consensus that you want to tell us that we have not covered in our discussion?
Well, I think we've covered quite a lot. Most of it. I mean, we've talked about cancer therapies. We've talked about rituximab specifically. We've talked about children, as well. We've talked about trying to immunize anyone around the household of a person who's got a cancer. There are sort of few other things which I probably would like to mention. I think we've not talked about patient who've had BMT, stem cell allogenic or autologous transplants, and I think these are the patients in whom COVID vaccine, if they already have had the bone marrow transplant, you cannot give the COVID vaccine. You should not be giving them immediately. You have to wait for at least 3 months, provided, or 3 to 6 months, provided the patient is not on any form of immunosuppressive therapy. Then give the vaccine, and then possibly start the immunosuppressive therapy again. So that's possibly the one thing. As far as the other thing which we've probably not discussed, or you may have discussed and I've missed the seminar, is the safety of the vaccine, the mRNA, the Astrazeneca. I'm sure there have been talks about the thrombotic events, especially the cerebral thrombosis or cavernous sinus thrombosis in patients who've had AstraZeneca. Yes, no doubt there have been cases, but if you actually look at the figures, it's about 4 in a million of AstraZeneca vaccine who have developed this thrombosis. So in UK, we've had 79 patients who've had thrombosis following the AstraZeneca vaccine amongst 8 million which have been vaccinated. So of the 8 million who received AstraZeneca vaccine, only say about 80 had thrombotic events, of which 19 were serious and four people passed away. So that's the, so it is about 4 in a million. So if you compare that with long haul flights, so elderly people who travel long haul flights, probably the thromboembolic episodes are far higher than the AstraZeneca vaccine itself. Following the thrombotic events, AstraZeneca vaccine was probably under pressure and said that they have stopped trials for AstraZeneca vaccine under 30s. But when you look at the 79 people who had thrombotic events, they were evenly distributed. It was not that only young people had thrombotic episodes. So there were people 60 years of age, there were 50s, and there were people who were 30 and 35 who had this. So the distribution was uniform, but for some reason AstraZeneca has decided to stop its trial for vaccinating individuals under 30 with AstraZeneca. So these are the things which probably, and I think the same thing happened with Johnson & Johnson vaccine as well. There were a few episodes of thrombotic episodes. But otherwise, yeah, I think you've covered most of it quite well.
Thank you, sir. Excellent point about thrombosis. We did not cover that in our consensus, but that's a recent issue. Thank you for bringing that up. Stem cell transplant we did cover, but I just skimmed through for want of time.
Oh, okay.
And this is my last slide.
Dr. Raja, pardon me, I may have missed it, but do we have a consensus on the use of steroids and concomitant vaccine? Did we talk about it? I may have missed it though.
No, sir. We talked about in general about immunosuppression, and that included steroids and methotrexate and everything, and we are okay to go ahead and vaccinate.
Absolutely.
And particularly in the setting of light transmission and severe transmission, I think absolutely go ahead. That's what we.
Great. Okay. Thank you.
Right. And this is a real world tweet that was forwarded by Purvish today to me, and this is a radiologist who had done 1,000 HRCT chest in this 1 month. And he says that his experience is about, all of them who had severe chest infection were unvaccinated people. And he hardly saw significant HRCT findings that were significant in vaccinated people. So that's very, very significant tweet today. And, I have completed my slide, and it's my duty to thank all of you. You're all the frontline warriors. I put it up here, and I thank all the panelists and the opportunity provided to me by Dr. Purvish and Amish and Sahoo. But it's also my duty to just run through a couple of interesting questions that I'm seeing. One of them, a funny question: what about vaccine? I think it's Amish. Amish always asks these, these kind of. Is vaccination center as a possibility for infective focus? That's what he asked. Is that right, Amish? I saw that.
Can I take that question?
Please.
Yeah. Okay. So to be honest, I think yes. See, it depends on what is the waiting area for the vaccination center between people who are trying to get in and people who have had their dose of vaccine and are waiting for 15 to 30 minutes. So if it is a closed room, then you see the ventilation in that closed room would not be effective. So the only place a closed room where ventilation is effective is an operation theater, where you have so many number of air changes per hour, which is not possible. So a lot of them actually did acquire. The reason why a lot of people said that, oh, we've had our first dose of vaccine, now we tested positive after a week for COVID-19. No wonder, because that probably was a hub where they did sort of catch the infection. And as you know, it takes about 3 weeks for the immune system to kick off a good immunogenic response following the first dose of vaccine. So yes, as long as it is a closed waiting area, it is a bad place. If it's an open area, then that's fine. Ventilation is not a problem.
So, Dr. Mukul and Dr. Raja sir, what we did at our center was initially it was what we observed exactly same 30 minutes waiting period. People used to chat. Then we made the waiting period outside. And last 20 days, what we have told them, those who have got car, let them sit in the car for 15 to 20 minutes.
Perfect.
We give them in writing that I will sit in my car for 20 to 30 minutes, and they sit there. And after that, we give them certificate and they drive off.
Perfect. I think this is really good.
All things, Raja sir, I asked this question, and Dr. Mukul also has experienced the same. So we have to be more careful about this.
True. No, that's a brilliant question.
Can I also come in?
It looked like a tongue-in-cheek question, but there is a purpose behind the question.
So,
absolutely.
That is what I did, sir. For my parents, when I took them for vaccination, I did all the billing. I went inside. I made sure that they sat inside the car for 15 minutes and there was hardly any contact. And at that time, people were doing that. To hell with the snap, to hell with the selfie, just get vaccinated and get the jab out. That's what they did.
Right. Hell with a selfie. Somebody mentioned.
Hell with a selfie.
But if I may add something.
Yeah.
If I may add something. Hello.
Yeah, please, sir.
Sir, I'm saying, despite my hall and the waiting space being AC,
I'm giving it over to Purvish Pai and Dr. Rajesh Jindal, and then thank you so much, Purvish Pai, for the opportunity. You can take over. Rajesh, please go ahead, Rajesh Pai.
But I was just saying that despite my waiting area being AC and all, I open a window and I place fans against the window. I mean, so that the flow of air is towards the outside of the hall. I don't have any stale air in the room. Even if anybody sneezes or coughs, the thing does not stay in the room for any length of time, which has been appreciated by all my patients also.
Awesome. Rajesh, that's a great
what
thing.
I do.
And Dr. Shyam Agarwal has also been saying the same thing. In fact, at Gangaram Hospital, they broke the walls because it was centralized air conditioning, and they broke all the walls in the OPD to give to make sure that ventilation is better. So Rajesh, great job. Exactly what is required.
To be honest, AC is bad. AC is bad.
Right. We are quite late, so I will not waste my time. Thank you very much, Dr. Raja. Thank you very much, all the panelists. And we hope to see you on Tuesday, 4th May at 7:30 p.m. At that time, we are going to discuss two important things: convalescent plasma therapy and bevacizumab. The expert panelists will include Tanvi Sood, Vivek Agarwala, Ajay Bafna, Prashant Mehta, Senthil Rajappa, Vamsi Krishna, and Shruti Kate. So once more, thank you very much, and hope to see you soon.